record this. Okay, so we are recording this webinar. So I want to welcome everybody. I am Eileen Michelli, and I'm with the Marfan Foundation. We're recording it. It will be available through our website and on our YouTube channel, and we'll send you all the link tomorrow so you can either watch it again or share it with anybody who was not able to participate live. So welcome to our series called Prepare for Victory, Virtual Medical Symposium Series. We created this program because we want to give you, no matter where you are in the world, the opportunity to hear the best information on Marfan syndrome, Loeys Dietz syndrome, Ehlers-Danlos syndrome, and other related conditions from our professional advisory board and other leading medical experts on these conditions. Our speaker tonight is, let me just put my screen here. Our speaker tonight is Dr. Hal Dietz. Dr. Dietz is a professor of pediatrics, genetics, and medicine and Howard Hughes Medical Institute investigator at Johns Hopkins. He's also the director of the Smilow Center for Marfan syndrome research, and he serves on the Foundation's professional advisory board. As you know, tonight's talk is on Loeys Dietz syndrome. So as I mentioned earlier, if you have questions during the presentation, please type them in the Q&A box, and we will leave time at the end to answer questions. So now, as we practice, I'm going to pass the control over to, one second, of course, now that we practiced that, I made a mistake. All right, so now I'm going to give Dr. Dietz the remote control, and he is going to start his presentation.
So I'm not seeing what we saw earlier. Let me see if this works. Share.
There you go. Look at that, it worked.
Remarkable. Good evening, everyone. It's really a pleasure to be with you. What I'd like to try to do today is to give you a comprehensive overview of Loeys Dietz syndrome, but also to look forward, to anticipate what the next 10 years might look like with regard to diagnosis, management, really to share with you my extreme sense of optimism and hope with regard to substantial improvements in the care of people with Loeys Dietz syndrome. So I have to start by discussing Marfan syndrome because it really established a foundation for us in our Loeys Dietz syndrome research. As many of you know, Marfan syndrome is a connective tissue disorder that's related to Loeys Dietz syndrome. It shows features in the eye, in the skeleton, and also in the cardiovascular system. In the upper left-hand corner, you can see what we call lens dislocation, that the eye lens has moved out of place. It's no longer in the center of the eye, but rather shifted upward. People with Marfan syndrome also typically have long bones. In this young man, you can see that his arms are very long relative to the length of his body. But most importantly, we see what we call aortic root enlargement. In this picture, you can see a candy cane looking structure that is the aorta. And at its base, you can see widening, which we call aortic root aneurysm or aortic root enlargement, which is the feature of Marfan syndrome and also Loeys Dietz syndrome that gives us greatest concern because an enlarged aortic root can be prone to tear. Now, a long time ago, back in 1991, we were able to show that mutations that cause Marfan syndrome occur in a gene that encodes a protein that we call fibrillin-1. I want to stress to you throughout this talk that the names of things are not all that important. What I really want you to do is to try to grasp general concepts, and I'll reinforce those important concepts along the way. So we knew that fibrillin-1 participates in the formation of structures in the body that we call microfibrils. These are small thread-like structures that exist between the cells of the body in the material that we call the extracellular matrix. In essence, this is sort of like the glue of the body that holds the cells together. We observed that there were numerous features of Marfan syndrome and other connective tissue disorders that could not be explained by simple weakness of the tissues. We had thought that a defect in the glue between the cells of the body would simply cause the tissues to be weak and to ultimately fail over time. But that model couldn't explain why the bones were long, why there were facial features of Marfan syndrome or Loeys Dietz syndrome. This really emphasized to us that there was something missing in the way that we were thinking about things. Now, many different experiments taught us that these microfibrils that are composed of fibrillin 1 serve a second important function in that they normally control the activity of a molecule in the body that's called TGF-beta. Again, the name is not important, but the concept is that this molecule called TGF-beta tells cells of our body how to behave. And in Marfan syndrome, we learned that when there was too little fibrillin 1, there was too much TGF-beta activity that ended up stimulating cells to behave abnormally. This TGF-beta cascade is a complicated cascade, but again, don't focus too much on concepts other than the fact that there was too much activity of this stimulatory molecule called TGF-beta. So that led us to the concept that a special class of blood pressure medications called angiotensin receptor blockers, with one prominent example being losartan, might be beneficial in conditions like Marfan syndrome, because besides lowering blood pressure, these medications had also shown the ability to tamp down, to suppress activity of this TGF-beta molecule. We went on to test losartan in mice that we had engineered to have Marfan syndrome. These mice, when given a sugar pill, when given placebo, showed a very rapid rate of aortic root growth, shown as the tall red bar, compared to mice that did not have Marfan syndrome, shown as the green bar. If we gave these mice a medication called propranolol that lowers blood pressure but does not suppress TGF-beta, we saw that the growth rate of the aorta was decreased, but it was still not down to normal levels. However, when we gave these mice this drug losartan that both lowered blood pressure and suppressed this TGF-beta molecule, we saw that the growth of the aorta was perfectly normal. In Marfan mice, given the sugar pill, the placebo, we saw that their aortic wall was greatly thickened and appeared very abnormal. If we gave those mice the medication propranolol that only lowered blood pressure, there was no improvement in the architecture of the blood vessel wall. But if we gave these mice losartan, the aortic wall looked perfectly normal. And this all occurred in association with suppression of TGF-beta activity. So this is really an exciting development, a breakthrough in understanding what's causing aortic aneurysm and aortic tear in Marfan syndrome. Now, there have been many trials of medications such as losartan in Marfan patients. And these drugs have generally shown that they are either as good or better than beta blocker medications. But there were a number of nuances to consider. They may not have added benefit on top of optimal beta blocker dosing, especially in mild cases. They may have greater benefit in younger people and those that have more severe disease. And they may require very high dosing, higher than typical dosing for the treatment of high blood pressure to have their greatest effect. Now, we continue to look at this situation very carefully. Again, we see in Marfan syndrome mice given a placebo or a sugar pill, there's very rapid aortic growth. When we gave really high doses of beta blocker medications that just lower blood pressure, again, we saw this reduction in aortic growth, but still not back to normal, not back to the green bar that's showing how a normal mouse behaves. If we gave a low dose of medications like losartan, we saw some improvement, but at each increment of dose, as the dose got higher and higher, we saw an even better performance of the aorta, all the way to the point where the aorta was actually getting smaller over time in mice that received the highest dose of losartan. So we have more to learn, but my general sense of this information is that both beta blockers and drugs like losartan show potential for the treatment of people with Marfan syndrome. Now, Loeys Dietz syndrome is a condition that we first recognized and described about 13 years ago. It was back in 2005. Prior to this time, there was really no appreciation that a different condition, that a condition that could be discriminated from Marfan syndrome even existed. And based upon that, there was no ability to learn about the unique features of this condition. There were no treatment protocols that were specifically tailored to people with Loeys Dietz syndrome. No treatment guidelines that we could share with physicians caring for these individuals. There were no medical tests to identify who was at risk for Loeys Dietz syndrome. And there was no research that was specifically focused on the cause and treatment of this condition. Now, back in 2005, my good friend and colleague Bart Loeys, who's shown in the upper right-hand corner, and I recognized that there were people in our clinic that we couldn't fully explain. They had some features in common with Marfan syndrome, like curvature of the spine, like chest wall deformity, like long fingers and aortic root enlargement, but also a number of unique features, like widely spaced eyes, or a cleft or break in the palate in the top of the mouth, or a split in the uvula in the back of the throat. There were other features that could be seen, deformities of the foot, other forms of heart disease. But most importantly, we recognized that the aorta in these people was behaving very differently than what you'd expect in Marfan syndrome. They were showing enlargement not just at the base of the aorta, but also of other arteries throughout the body. And we also noticed, very importantly, that these aneurysms or areas of enlargement tended to tear or rupture at younger ages and at smaller sizes when compared to Marfan syndrome. At Johns Hopkins, we've now had the opportunity to care for greater than 500 families. This slide is a little out of date, of people with Loeys Dietz syndrome. And we've also had the privilege to hear about many, many more families through our associations with colleagues throughout the world. As you know, this condition is now referred to as Loeys Dietz syndrome. Now, I'm going to go through some of the physical features, and I'll stress when a physical feature only helps us in making the diagnosis, and also when a physical feature gives us concern, when it's a problem that needs to be addressed. As I mentioned, there are often features in what we call the craniofacial system. That's abnormalities of the head and of the face. including premature fusion of the skull, a situation that we call craniosynostosis, widely spaced eyes, something called hypertelorism, again, a cleft palate. So all of those features are useful diagnostically. They're different from what you expect in Marfan syndrome. The uvula is something that we pay a lot of attention to, not because it's a problem per se, but rather because it really is important in keying us into the diagnosis of Loeys Dietz syndrome. It's abnormal in about 90% of people that are ultimately shown to have Loeys Dietz syndrome. You can see that there are many different flavors of abnormalities of the uvula, from one that simply appears wide to one that has a crease down the middle, one that's only split at the tip, to one that is fully split, where it appears that there are two separate uvulas in the back of the throat. There are features that we notice in young children with Marfan syndrome. This vein that crosses the bridge of the nose is very common and often keys us into the diagnosis. The white part of the eye is something that we call the sclera. And in people with Loeys Dietz syndrome, it often has a gray or blue appearance, as you can appreciate in the young children on the top of this slide, especially in the young girl on the upper left. There also can be abnormalities of alignment of the eyes, often with one eye that looks outward while the other eye is looking straight forward. This is a situation that we call exotropia, and it's a very important feature to pay attention to because during early childhood, if one eye sees less well than the other, the brain can simply learn to tune out information from the less good eye. And if that goes on long enough, it can become a permanent problem. The brain simply lacks the ability to process information from the less good eye. So this exotropia issue is something important to recognize early in life and to have treated by an ophthalmologist. The treatments can be very simple, simply by patching the good eye. You can force the brain to learn to process information through the less good eye. But again, it's something important for you and your pediatrician to recognize early in childhood so it can be treated. There are many skeletal features that are seen in Loeys Dietz syndrome, including the long fingers that we often observe in people with Marfan syndrome. Many of the joints can be loose, but for some unexplained reason, the finger joints can actually be tight, something that we call joint contracture. Again, this is something important to recognize early, and often a physical therapist can help maximize function of tight joints. The feet can be turned inward in someone with Loeys Dietz syndrome. If this is a severe situation in early childhood, around the time of birth, it's something that's called club foot deformity. Again, can respond dramatically to treatment, so something that's important to diagnose early in life. Chest wall deformity is common. The chest wall can protrude outward or indent inward. This is something that typically doesn't cause a medical problem, but often can be a significant cosmetic problem that young people would prefer to have fixed. And there are effective ways of dealing with chest wall deformity. And then curvature of the spine, so-called scoliosis, is also common in Loeys Dietz syndrome. And if severe, if greater than about 25 degrees or so, can require really specific treatments, sometimes treated with bracing, sometimes requiring a surgical procedure. Something that's unique to Loeys Dietz syndrome that we pay a lot of attention to is the possibility of a problem in the spine in the neck, something we called cervical spine malformation or instability. It's present in about half of all people with Loeys Dietz syndrome and can put someone at risk for injury to the spinal cord. We recommend that at the time of diagnosis, people have x-rays of their neck to look for malformation or instability. If severe, this can require surgical stabilization, as you can see in the two young people at the upper right side of the slide. Sometimes this is complicated by poor bone healing, so it's very important for your doctors to be looking at the quality of the bone. Something that we call osteoporosis means that the bone doesn't have enough calcium, and can be treated with vitamin supplements and also calcium supplements. So we do believe that the initial evaluation should include neck films with the head bent forward and bent back, and also something called a DEXA scan that looks at the quality of the bone, the amount of calcium in the bone. Allergies, we've learned, are very common in people with Loeys Dietz syndrome. One type of allergy that's quite common is food allergy, which can be multiple, meaning someone is sensitive to multiple foods, and can also be severe. The most common types of food allergies include milk, eggs, peanuts, other tree nuts, and fish, especially shellfish. Food allergy responses can range from low-grade symptoms to acute life-threatening reactions that would require carrying an EpiPen to control the allergic reaction. We also commonly see seasonal allergies and other allergic conditions such as asthma or eczema. So we do think that people with Loeys Dietz syndrome should discuss this with their pediatrician and often would benefit from evaluation and management by an allergist. In general, we suggest avoiding decongestant medications that can be suggested in people with allergies. But these medications may cause problems in people with Loeys Dietz syndrome because they can stimulate the heart and increase the blood pressure. There are a number of gastrointestinal conditions that can be seen in Loeys Dietz syndrome. One of the most common is a condition called eosinophilic esophagitis, a form of inflammation of the tube going from the mouth to the stomach. When young children have eosinophilic esophagitis, they can show pretty nonspecific findings, such as vomiting or abdominal pain. Some of these children just simply are not interested in eating, and they show poor weight gain. But often it's hard to get a specific comment that their throat hurts or that it hurts to swallow. So the pediatrician needs to be sensitive to many possible clues that this type of inflammation may be present. In older children and adults, it's often easier to get a specific history that they have trouble swallowing, that there's a sensation that food is getting stuck, or that there's chest pain. This condition, eosinophilic esophagitis, is often very effectively managed simply by finding the food that's triggering an allergic response. Again, very important to have this evaluated by a gastroenterologist and perhaps by an allergist. In a smaller subset of people, there can be a more severe inflammation called inflammatory bowel disease. This can be associated with diarrhea or with blood in the stool. And this type of finding really should be evaluated very early. If there's any sense of severe gastrointestinal problems, it's essential to see a gastroenterologist who can help manage the inflammation. Now, many of you probably know that the blood vessels in Loeys Dietz syndrome can be windy, something that we call tortuous. As you can see in the pictures on the right, some of these blood vessels make loops as they're going to their destination. This is particularly common in the blood vessels in the neck, but can be seen in other blood vessels throughout the body. When we first saw this, we worried that windy or tortuous blood vessels might be dangerous, that they might be prone to kink and to prevent blood flow from reaching the tissues. But we've simply learned over the last 15 years or so that this is not the case, that windy blood vessels help us make the diagnosis of Loeys Dietz syndrome, but in general, it's not a condition to worry about. There are other features of Loeys Dietz syndrome that we've learned over the years. Dental anomalies can be an important part of Loeys Dietz syndrome, including poor enamel of the teeth that makes someone prone to cavities, also discoloration of the teeth. This can respond to fluoride supplementation and is something that you should talk about with your dentist. As I mentioned, there can be ophthalmologic or eye findings in Loeys Dietz syndrome, including exotropia that we also talked about. There can be nearsightedness, and there is a small but significant risk of a problem called retinal detachment, where the membrane on the back of the eye that brings information to the brain can separate from the eye and cause very significant vision impairment. Because of this, we do recommend that people with Loeys Dietz syndrome avoid activities where you can expect a sharp blow to the head. We do recommend that if there is ever a sudden and unexplained change in vision, that it should be evaluated in an emergency room immediately. As I also mentioned, there can be low bone density. If someone is having recurrent fractures, they should be checked for vitamin D deficiency. In general, all of us throughout the world are at greater risk for vitamin D deficiency because we spend less time outside in the sunlight than we used to. But this can be a particular problem in people with Loeys Dietz syndrome. So we do recommend a blood test to look at the vitamin D levels. If they are low, that can be supplemented. If the bone problems are severe, then we do recommend an evaluation by an endocrinologist. Headaches are also common in Loeys Dietz syndrome and some other connective tissue disorders. We don't fully understand why headaches can be more severe and more common, but we do find that they respond to good hydration. So we suggest that people stay very well hydrated by drinking frequently. Some medications that treat headaches do that by causing constriction of the blood vessels, which we think can be dangerous for people with Loeys Dietz syndrome. So we do recommend avoiding a prescription class of medications for headaches that are called triptans. If ever your doctor is discussing giving you a prescription for headaches, you should discuss this situation with them and let them know that there are some headache medications that we think should be avoided. Now, we've now learned that Loeys Dietz syndrome is also caused by abnormalities in the TGF-beta pathway. The first two genes that we found affect what we call the receptor for TGF-beta that sits at the cell surface and binds the TGF-beta molecule. We also found that in people, as in mice that had Marfan syndrome, we see a strong signal for high TGF-beta signaling, high TGF-beta activity. So this gave us hope that some of the medications that we had uncovered for the care of people with Marfan syndrome might also be relevant to people with Loeys Dietz syndrome. Since this time, we've now learned that other defects along this entire TGF-beta signaling cascade can commonly cause Loeys Dietz syndrome. There are now 6 different types of Loeys Dietz syndrome that have been described, and every one of them relates to the same TGF-beta signaling pathway. We also learned that a related condition called Sprintzen-Goldberg syndrome that shows virtually all the features of Loeys Dietz syndrome also relates to this TGF-beta signaling pathway. So the message is that nature is telling us something and that we should listen carefully. And what nature is telling us is that the central aspect of the problem relates to TGF-beta signaling, and therefore our strong belief is that the central aspect of the solution of effective treatments will also relate to TGF-beta signaling. So my first prediction for the next 10 years is that within that time, we will know all of the genes for Loeys Dietz syndrome and most other aneurysm conditions, and that we will all therefore be able to identify these people before they develop problems, hopefully with the ability to prevent problems before they happen. My second prediction is that within 10 years, we will have a truly comprehensive international database that will allow physicians and researchers to identify rare but important features of Loeys Dietz syndrome, and that we will be able to share this information efficiently, which will allow earlier recognition of patterns. We do know now that knowing the specific gene and even the specific gene change for a given family will allow us to predict the issues that they will have in the future, when they might occur, and how they are best prevented or treated. We do know that blood vessels are a major problem in people with Loeys Dietz syndrome. As I mentioned, we commonly see enlargement at the root of the aorta in almost 90% of people, but that we also see aneurysms throughout the arterial tree, really from the head all the way down to the top of the legs. So on this basis, we recommend that an imaging study be done to look at blood vessels from the head through the pelvis at the time of diagnosis. This could either be an MRA scan or something we call a CTA scan. They both give beautiful pictures, but we have preference for an MRA scan if possible because it doesn't require radiation. So it is a safe way to follow somebody's blood vessels throughout their entire lifetime. 1, 2, 3, 5 CT scans are fine, but our bodies have memory for the amount of radiation that they've seen over our lifetimes. So we need to pay attention, and someone that we expect will need imaging studies for many, many, many years. The best bet is to try to use MRA when possible and to avoid the radiation exposure in CT scans. We know that aortic tear, something we call aortic dissection, is common in Loeys Dietz syndrome and that it can occur at young ages. The youngest person that we saw with the tear of the aorta was only 6 months old. We do know that tears can happen throughout the entire aorta, from the base of the aorta called the root all the way down to the abdominal aorta. And we also know that these tears can happen at small aortic dimensions, as small as around 4 centimeters. We do know that aortic repair is safe. When we first recognized Loeys Dietz syndrome, we worried that these blood vessels would be particularly fragile and that they might not respond well to surgery. But in reality, now with lots of experience at many centers throughout the world, we've learned that that's not the case. So the general rule is that since the aorta can tear at a small dimension, and since aortic surgery is safe, that we're more aggressive with aortic surgery in people with Loeys Dietz syndrome. We do it earlier in life and at smaller aortic sizes. So the take-home message is that vascular disease occurs throughout the arterial tree, and therefore we have to image widely, that aneurysms tend to rupture at smaller dimensions, but that the gene that's involved in the type of Loeys Dietz syndrome that someone has helps us to predict this. In general, types 1 and 2 are worse than types 3, 4, 5, and 6. And they are worse than what we see in Sprintz and Goldberg syndrome. So simply knowing your gene and mutation helps us to make wise choices with regard to when surgery should be done. We now have gone on to make mice with Loeys Dietz syndrome by introducing mutations that we had previously seen in people into the corresponding gene in the mouse. We've noticed that these mice develop the skeletal features of Loeys Dietz syndrome, such as curvature of the spine that's seen over on the right. We've found that these mice also show the craniofacial features of Loeys Dietz syndrome, including premature fusion of the skull bones. But most importantly, we found that these mice also show all the cardiovascular aspects of Loeys Dietz syndrome, including enlargement of the root of the aorta and abnormalities within the wall of the aorta that show us that the tissue is weak and getting weaker over time. When we left Loeys Dietz syndrome mice untreated and allowed their aortas to get very big, we saw that they did show death due to aortic tear. And this was an important thing. This is what we were hoping for, because if the mice showed this abnormality, then we could test treatments to prevent this abnormality. We went on to show that these mice show evidence of too much TGF-beta activity, just as we had seen in Marfan syndrome. And we went on to test losartan in mice that had Loeys Dietz syndrome. In untreated mice, we saw big aortas. In losartan-treated mice, we saw aortas that were perfectly normal in size. In mice that were treated with other medications like beta blockers, we saw that there was no improvement. So this really gave us strong conviction that as of right now, medications such as losartan appear to be the best bet for people with Loeys Dietz syndrome. Again, fortunately, they're also very well tolerated. So we don't see lots of side effects. Certainly, there are no long-term side effects of using these medications in children and in adults. So the take-home message is, as in Marfan syndrome, drugs such as losartan could prevent abnormal aortic growth in mouse models. And we truly believe that they hold great promise for the treatment of people with Loeys Dietz syndrome. Importantly, it's important to stress that the goal is not simply to lower blood pressure, that we're also after a biochemical effect, the suppression of this TGF-beta molecule. So it does not make sense to just use a tiny bit of losartan because someone's blood pressure is also normal. We believe that you have to get to high dosing to have the desirable benefit, biochemical effect that we're after. We certainly have to do more work along these lines, but we have shared and published guidelines to help physicians caring for people with Loeys Dietz syndrome to make good choices with regard to what medication to use and what dose of medication to use. We've been able to identify an entire path of abnormalities that ultimately leads to abnormal blood vessel maintenance and strength in Loeys Dietz syndrome. On this basis, we have many different strategies that we're exploring for the treatment of people. Importantly, we've already begun to partner with drug companies to develop new medications to address these specific places of vulnerability for Loeys Dietz syndrome. So we believe that we're already in a better place, that drugs like losartan hold promise, but our hope is that within the next 10 years, there will be even more effective treatments. We've now gone on to test some of these treatments in mouse models very comprehensively. Here I'm showing you 6 normal mice. I'm showing you their normal appearing aortic root. If you look at Loeys Dietz syndrome mice, you can see that these aortic roots are extremely large, that the aortic wall is very thickened. These are all telltale signs of too much TGF-beta activity. With one of our specific treatments, you can see that in Loeys Dietz syndrome mice, we've been able to make the aortas appear perfectly normal and to stay perfectly normal over time. So we're really hopeful that some of these new treatment strategies have the potential to keep the aorta in a normal, at a normal size and without the risk of aortic tear for a full lifetime. We now know that these mice also develop allergies. We know that they also develop eosinophilic esophagitis, the type of gastrointestinal inflammation that I was talking about earlier. So we think that there's the strong potential that we'll be able to also come up with treatments for this aspect of Loeys Dietz syndrome. So my prediction is that 10 years from now, basic science research will have fully elucidated all of the mechanisms for Loeys Dietz syndrome, that on this basis, there will be more effective medical treatments for all aspects of the condition, including aneurysm, but also allergy and gastrointestinal inflammation. We are hopeful that some of the new revolutionary genetic methods that you may have read about in places like Time magazine to correct abnormal genes, that they may ultimately be applicable for connective tissue disorders. It's going to take a lot of advancement, a lot of technical advancement to be able to correct the cells all throughout the body. But in 10 years, who knows? We may be able to fix the basic genetic alteration in the aorta and other tissues. It seems like a long stretch right now. But importantly, 10 years ago, I couldn't even imagine what we can do now. On that basis, my bet is I can't even imagine what we're going to be able to do 10 years from now. And we do know that pregnant women with connective tissue disorders can show a strong risk for tear of the aorta. We've recently come up with a hypothesis that that might relate to a hormone called oxytocin, that peaks toward the end of pregnancy to cause the woman to begin contractions to deliver a baby. We know that the release of this hormone is also maintained during breastfeeding. And that got us to wonder whether breastfeeding practices might influence the risk to a woman with Marfan syndrome or other connective tissue disorders. So on this basis, we used one of our mouse models of Marfan syndrome, where essentially we see close to 100% death due to aortic tear within the first 30 days after delivery, if those mice are allowed to lactate to support their pups through breastfeeding. But if you simply take the pups away right after birth to prevent lactation, survival jumps all the way up to 70% just by avoiding breastfeeding. We then gave the mice a drug that blocks oxytocin, so it prevents this hormone from stimulating cells within the aorta. And when we did that, we basically saw that all the mice survived. So they still got pregnant, they still delivered, they were still able to breastfeed, but they avoided tear due to aortic dissection. So we're hopeful that this type of strategy will allow women with connective tissue disorders to have safer pregnancies in the future, perhaps by choosing not to breastfeed, perhaps by receiving medications that block the hormone oxytocin. So the take-home message is that I think we've made great progress in understanding what's driving this complication, and that in the future, either maneuvers like avoiding breastfeeding or medications may help to eliminate, to reduce or eliminate this risk. So my fourth prediction is that within 10 years, we'll have new and effective options to ensure safe pregnancy, and that improved genetic testing will allow people with LDS to avoid passing the condition on to the next generation. We have prepared a primer for physicians caring for individuals with Loeys Dietz syndrome. We've tried to cover all of the important topics shown on the bottom of the slide. This paper has been published, so it is widely available in the medical literature. We're also able to share copies of this paper electronically, and that can be made available through the Marfan Foundation website. So it's a place to let your physicians know where they can find information. Medical management in general, right now, we suggest angiotensin receptor blockers like losartan at high dosing. We do suggest some exercise restrictions to avoid things like weightlifting, avoid things like pushing yourself to exhaustion, but we do believe that regular moving kinds of exercises done in moderation are good for people with Loeys Dietz syndrome and should be encouraged. We do recommend frequent imaging, at least once per year, and also widespread imaging from the head through the pelvis, perhaps every 1 to 2 years. We do have now specific recommendations about when surgery should be considered. This is covered in that primer article that I just showed to you, but we're always happy to talk to physicians throughout the country and throughout the world to help them make the best decisions regarding when surgery should be done. So in the past, medical science has focused on big populations, so that we've asked the simple question, what works best for the average patient with a given condition? In the future, I think from now forward, we will be asking what works best for this particular patient sitting in front of me. That's based upon their specific gene that's involved, their specific mutation, their family history. We try to integrate all sorts of information to make the best decision for you, not for everyone with Loeys Dietz syndrome in general. So we've come to appreciate that everybody with this condition is an individual that we need to learn about, we need to understand, and that we need to respect as an individual in order to make the wisest decisions. We've made progress in this regard throughout the world. There are over 2,000 families that we've learned about. There are multi-national collaborative networks now that are helping us to achieve comprehensive information, again, designed to share information very efficiently. There are wonderful patient advocacy foundations for Loeys Dietz syndrome, both in the United States and in Canada, that provide community and advocacy for patients, development and management guidelines, and education and research. We hope and anticipate and are trying to foster the development of advocacy groups elsewhere in the world. So my final take-home message is hope and extreme optimism. These are some of the young folks that I have the privilege of caring for with Loeys Dietz syndrome. And you can see we're getting a big thumbs up because of how nicely things are progressing and how much optimism there is for the future. So I think that is the end of my presentation, and I'd be happy to try to address some of your questions. Thank you for your attention.
Well, thank you so much, Hal. That was really great. I was going to talk a little bit first about backpack health, but what I'm going to do instead, because I do want to get to the questions. Can you see my screen, Hal? Backpack health? Yes. Okay, great. Instead of doing that, I'm just going to go right to the questions because that's more important right now, and I will send this information in the follow-up email to everybody. So let's see. How common are dissections in arteries and vessels other than in the aorta in patients with Loeys Dietz?
Yeah, so that's an excellent question. We have recognized that there are other blood vessels that are prone to dissection. Very importantly, in the neck, we also see a risk of dissection in certain blood vessels in the abdomen and also into the pelvis and the upper portion of the legs. There are some guidelines regarding when those blood vessels should be considered for surgery. We rely on help from our colleagues in radiology and also our colleagues in vascular surgery to make those decisions. In general, we think that operations are the best way to go for prevention of a tear of blood vessels. But sometimes, based upon the location of an enlargement of a blood vessel, the best approach might be to use a catheter to insert what we call a stent. It's basically a support inside the blood vessel that strengthens the blood vessel and prevents a tear from happening. Because the risk to other blood vessels throughout the body is the reason why we suggest that MRA or CT scans should be done about once every 1 to 2 years to look for emerging problems.
Great. I actually have a follow-up question to that somebody else had sent about with the stenting. Their doctor said that the arteries are too tortuous and it's risky with the stenting. And you just mentioned stenting. So can you just address that?
Yeah. So what we try to do is to make the best decision for an individual patient who we're caring for. The tortuosity, the windiness of the blood vessels can sometimes make it difficult to get a catheter into the aneurysm that needs to be supported. And in that circumstance, it might be a better choice to use a surgical procedure rather than a catheter-based procedure. In other circumstances, the tortuosity is not a big problem. It's not a limiting factor in allowing us to use catheters to support blood vessels. So it really depends on where the aneurysm is and the specific circumstance for a given individual.
Okay. Great, thank you. So another question, what is the relationship between Loeys Dietz and fibromuscular dysplasia? Maybe you can tell us what that is first, fibromuscular dysplasia.
Yeah, so fibromuscular dysplasia is a poorly understood vascular disorder, often involving the vessels in the neck, also often involving the blood vessels that go from the aorta to the kidneys. In fibromuscular dysplasia, there are areas of tightening of blood vessels that we call stenosis, followed by areas of widening of blood vessels. Often those are repeated over and over again. It almost looks like beads on a string or a string of pearls because you have alternating narrowing and then widening of blood vessels. We don't know the cause of fibromuscular dysplasia. It is a condition that has a genetic component, but so far efforts to find major genes that are causing fibromuscular dysplasia have not yet been successful. So I really don't have an ability to talk about similarities between the cause of Loeys Dietz syndrome and fibromuscular dysplasia. Importantly, people with fibromuscular dysplasia do not typically show outward features of a connective tissue disorder. So they would not show the skin and the skeletal and the craniofacial features that are so common in Loeys Dietz syndrome.
Okay, thank you. Back to, I guess, basics. What is the diagnostic pathway for Loeys Dietz syndrome? Is a normal echo enough to rule it out? So what would the steps be if somebody recognizes it or if they're suspected?
Yeah, so a normal echo typically would not be sufficient to say with certainty that someone doesn't have Loeys Dietz syndrome. You know, that's especially true for young people. Sometimes the risk of aneurysm emerges over time as someone ages. There are adults with Loeys Dietz syndrome that I know of that do not have aortic root enlargement. That doesn't mean that they're not at risk for problems in other blood vessels throughout the body. So that would not be a reason to simply decide not to image elsewhere. If someone shows the facial and the skeletal and the skin features of Loeys Dietz syndrome, they also show the tortuous blood vessels, but they don't show any area of enlargement. I think the right choice would be to do DNA testing to look at all of the genes that we know can cause Loeys Dietz syndrome to see if we could find definitive evidence that someone has that underlying predisposition. My bet is that there are still some more genes to find. So if someone has all of the features of Loeys Dietz syndrome, including aortic enlargement, but has negative gene testing, that also doesn't mean that they don't have the condition. It just means that we don't yet know the gene that's specifically involved.
Okay, we only have a couple more minutes, so I'm going to just ask one more question here. The kind of a few people have asked about. It's about the dosing of losartan and losartan versus valsartan. Can you talk about those two?
Yeah, so as I mentioned, we do have strong incentive to get to high dosing of medications like losartan. For losartan, for an adult or a bigger adolescent, we would suggest that a dose of at least 100 milligrams per day is where we'd like to be. For children, we try to reach a dose of 2 milligrams per kilogram of body weight per day. So if someone weighed 25 kilograms, we'd be shooting for 2 times that amount, or 50 milligrams of losartan per day. There are other drugs in the same class as losartan. One is called valsartan, another is called irbesartan. Some of these drugs have a broader dosing range, so we have greater freedom to try to reach even higher dosing. You know, if we're treating someone with what's considered maximal dosing of losartan, and we're still seeing that their aorta is showing abnormal growth, we might try to switch to one of the other medications that have more liberal dosing. One of them that we commonly use is a drug called irbesartan. For an adult, we would recommend a dose of at least 300 milligrams per day. For a child, we try to reach about 8 milligrams per kilogram of body weight per day of irbesartan.
Okay, great. Thank you for that. So there are a lot more questions. If anybody has put questions in the chat box, it'd be great if you can put them in the Q&A box, because we will follow up. And Jan Lynch, the nurse in our Help Center, who you see her picture now, she will get back to you. And for anything that we don't have information on, she will obviously connect with Dr. Dietz. And so we will get you your questions answered, because that is what we're here for. So I want to thank Dr. Dietz tonight for the presentation, for his time. We will be sending a link out tomorrow, and with a link to the webinar and also some other links that are related to this talk. You can go to our webpage, and if you go to marfan.org, patients and families, you see on the side virtual medical symposium series. So you'll see the recording for this webinar, and then you'll see what's coming up next, and you'll see recordings of past webinars as well. So I want to thank everybody for joining us tonight, and please, we're always here for you. Any other suggestions for talks or any other questions, please let us know. So thank you all again, and have a great night.
Bye, everyone.
Bye-bye.